Okay, the next speaker is we have John Fortunato from Lurie Children's Hospital in Chicago, who's going to be discussing the assessment and treatment of pyloric dysfunction in children with chronic nausea and vomiting.
Well, while we're getting this on the laptop, at first I do want to express my gratitude for the invitation to be part of this community, to speak and to learn from this meeting. Oh, perfect, thank you. And is this the I turn this on?
This is
Okay. Okay. Second of all, just as far as my background, it's unusual. I spent the first part of my career as a general surgeon, focusing in vascular, and then decided to become a pediatric gastroenterologist. It gives me a unique and somewhat maybe disturbing perspective on life. And third, one of my hobbies, I very much enjoy writing. So I think this is a story, and like any good story arc, I think we have to kind of start with some background and the characters, and then focus on the actual climax of the story, which will be the stomach for this case. I do have a couple disclosures. I've been fortunate to have grant funding support from NASPGHAN, our PHGI society. We're looking at developing interactive technology for disorders of gut-brain interaction. And my other weird component, I went back to business school as an old person, and I'm trying to actually develop telehealth services for complex pediatric GI care. That will not be part of this talk. So I think to begin, and looking at this at the high level, motility is complicated. And one of the things I've found over time is looking very nuanced versus high level can get very confusing. So I think really the important thing, especially when we're talking about RASopathy, any condition in general, is it's not as simple as the gut. There's always more to it. And so how do you actually assess patients with complex symptoms and diverse symptoms? And I think really this is not to get warm and fuzzy on a Saturday morning, but the whole patient matters, and this holistic approach is important because phenotypes matter. A lot of the discussions during this conference will be genetic mutation, the genotypic part of patients, but pairing that genotype and phenotype is essential to understanding mechanistically what's going on. So again, looking at mechanisms is what I enjoy doing. Looking at the significance of comorbidities is also key, because the analogy is if you come see a gastroenterologist and there's blood coming out of your eyes, you don't want to say, well, I don't want to look at your eyes right now, I'm a stomach guy. You have to look at the whole picture. And then really, I want to focus on when to treat, or when to test, and when not to test, with the notion that any test that you recommend to a parent, patient, has to be actionable in terms of the question that comes before the test and the actionable consequence in terms of treatment. And maybe that's a little bit of the surgeon in me, in the sense that operating on abdomen, just looking to see what we would find, was never an acceptable proposal to my professors. And I'm looking at my watch, not because I want to rush things along, but I'm committed to keeping to time. So if I look at my watch, please don't take it personally. It's for the to keep to time. But again, what is the rationale for talking about GI manifestations, particularly the stomach? If we look at some of the common RASopathies, and I highlighted particularly on the right column, delayed gastric emptying, gastroparesis being a component of this condition. And what is gastroparesis? And not to leave it as a cliffhanger, but let's start telling the story and start introducing the stakeholders. So the first thing is, GI symptoms are not easy to define. I'm a nausea person, take that in the way it's intended. Nausea is a very personal and private sensation. One of my mentors, Ken Cook, actually, that was one of the first lines in his book on nausea, is that it's hard to describe. And just because children can't verbally communicate it doesn't mean they can't communicate that as a symptom. So I think it's really key, as we assess patients on a clinical basis, to really look at the patient and talk to the parent, because parents can generally get a sense something is not right. Vomiting is not easy, but it's more objective. One of the questions we frequently ask patients who can answer us is, where is your nausea? Is it here in your head, in your belly? Is it lower down? And it's interesting. I've asked that question for 20 years now, thinking that people would think I'm completely bananas. And each time I usually get a very focused answer. Some patients with migraine type headaches, this is where their nausea starts, versus the stomach versus lower. So again, it's just that finesse of being able to ask the right questions and understand the right circumstances. Why is it important? Because we are in a hammer and nail society. As gastroenterologists, we do like looking in stomachs and colons, I guess, and it comes with implications. And we do a lot of tests, and I've had patients who've come to us who've had multiple colonoscopies. If you're 16 years old and you don't have an inflammatory issue, you probably shouldn't have 3 colonoscopies before you're like my age. And so it does have implications in terms of cost, it has implications in terms of complications, and also in terms of not getting to a step closer to a diagnosis, which is extraordinarily vexing and frustrating for parents. Coming out of a procedure suite and saying, oh, everything looks normal, and translating that into a parent in tears has implications. We want to find something, again, that's actionable in terms of treating the condition. So this is the beginning. It's defining the patient population. How do you link heterogeneous symptoms? How do you ask the right questions, or what are the right questions towards defining the phenotype to be able to find meaningful impact with the genotype? And this is a study we did from a different population with autonomic and nausea symptoms. And I just bring this up because one of the things that we looked at was when you look at all the comorbidities, this is actually the orthostatic intolerance nausea patient population. And you look at the table on the right, 90% of these patients had abdominal pain, and 82% headaches, 81% orthostatic intolerance, and go through the list. But when you look at some of the routine tests that were done just seeing a gastroenterologist, the majority of these patients actually who had a colonoscopy didn't have any pathology or any identified. So these were patients that had a 85% negative rate for colonoscopy. So what it really underscores is knowing the question before you go into doing the procedure. And I think this applies to all patients, particularly with complex and illness and comorbidities. So my recent area of research is patient-reported outcomes, and actually looking to see if you can actually mathematically model how an intake, how symptoms actually correspond to underlying conditions and mechanisms. So all of our patients actually go through this litany of sort of a painful exercise of going through all the symptoms with our intake questionnaire. And we've actually developed different, I would say, packets or groups of questionnaires as related to the presenting symptoms. So for instance, for our patients who have autonomic or questionable autonomic dysregulation, we use the Compass 31. The nausea profile, which I'll allude to in just a minute, has been very instrumental in terms of looking at, again, multi-system contributions to nausea. We're big fans of the patient-reported outcomes metrics, the PROMIS profile, where we start to look at the impact of both comorbid psychological disability indices, the global health indices, sleep, and even in some cases, joint hypermobility in terms of Ehlers-Danlos. And so this is where I like to try to take the story at this point. This is a mosaic. So we have all those little tiles that we're trying to put together into a beautiful picture on the right. And that really is how I see things, because it's not all those tiles are not brown or green, meaning GI. It's a matter of putting those together in the context of other systems. So the second point I'll bring up is it always usually starts with a case. And so how I got into this world of autonomic GI dysfunction really was from a patient who said, oh, I'm sick all the time, I'm nauseated, oh, I pass out, but that's the cardiologist. And the truth was there was a relationship that was sort of striking at that point. So when we talk about an N of 1, that was the N of 1, and here we are now 20 years later talking about this connection. So these are the 3 domains of the nausea profile. And I just bring this up, again, not to dwell too much into it before we get directly to the stomach, but the notion of the somatic component, autonomic symptoms, dizziness, fatigue, that's a part of this questionnaire that Eric Muth designed back in late 90s. There's a gastric component, it makes sense. There's an emotional component. And again, really, at the end of the day, this is a biopsychosocial a model of care. It has to be, because the question, chicken and egg, cause and consequence. Do children who have chronic symptoms for years at a time not become anxious? Of course they do. I become anxious thinking about it. So the question is, how much of an impact does that have in the timeline or the sequence of events from symptom onset to where we are now? So I just want to put this slide up there again, just to underscore that disorders of gut-brain interaction truly are disorders of gut-brain interaction. And so again, getting back to my surgical days, what's the problem? All the data is potentially relevant. Wouldn't it be nice if there was like one problem fit all? Like if there was like a one motility drug, put us out of business and make life a lot easier, but it's not the case. And I do bring up the key point. There's a Latin expression that I can't remember, but correlation does not always equal causation. So again, just because you find something, we treat the patient, not necessarily the diagnostic test. The diagnostic test is aimed to augment our understanding. I think I'm doing okay. So again, one of the things, this is where my story began. We started with that one patient, we started seeing this association of orthostatic intolerance and nausea. We actually treated the orthostatic intolerance and actually saw demonstrable improvement in nausea and some other GI symptoms. And just in the interest of time, I'm going to go through this a little bit quicker because I'm still committed to trying to stay on time. So we took it one step further, and as we approached the stomach, and we thought, well, is it a muscle issue? This was brought up. Is it an electrical or a nerve issue? Is it a combination? So we basically did an EKG of their stomachs. And it sounds strange to say the electrogastrogram. It's controversial in terms of its application to the GI tract, but basically it's been around since Walter Tumpier, a pediatrician, 1930s, actually developed this technology by accident. He was actually trying to look at EKGs in neonates and found that this annoying background noise was getting in the way. This is his annoying background noise is kind of my career. And so we started looking at those patients who improved treating their orthostatic intolerance. And lo and behold, we actually started seeing some electrical patterns that were interesting. We saw patients who had super normal 3-cycle per minute waves on the top, and some that were atypical and faster rhythms than we would have expected. And I have to bring Ken Cook back into it again because the two of us were sitting in the office talking about it and talking about some of his younger patients. He's an adult gastroenterologist, and he said, gee, there's this patient population that is just too normal. They have their 3-cycle per minute rhythm, which is that extra spiky thing in the left corner. It's like it's too perfect. And then we thought, well, what is motility? It's about contraction, but it's also about receptive relaxation. And so we've always thought, well, contraction or lack of contraction. But truthfully, the analogy was brought up with the biceps. You can't contract unless you relax. If you try to lift a weight and your triceps don't relax, your biceps are not going to do very much. And so we were manometry people, and we thought, well, what is going on? But are we seeing a neuropathic pattern? The truth is, we were seeing patients who had normal antegrade peristalsis in their stomach, but way high, or for those in New England, wicked high antral pressures. And it made us think in terms of the physics of it. If your stomach is contracting at 600 millimeters of mercury and you're cramping and you're responding to typical motility medications like erythromycin with more pain, is there a potential outlet issue? And this is the chicken and the egg, contraction versus receptive relaxation. So then we kind of got interested in the pylorus, and one of my former trainees, now one of our faculty, was looking at this with us with the idea we could put Botox in the 5 minutes. Okay, I know where to cut now. We started looking at the pylorus as a potential obstructing bump in the road, as it were. And Botox has been used frequently in the past to relax the pylorus. Some patients get better, some don't. What is the difference? And so we actually start to apply impedance planimetry, excuse me. The trade name is EndoFlip. That's actually a catheter. We're actually looking through the balloon. So it's a balloon with pressure sensors. And one of the things we found, and again, I apologize if I'm starting to ramp up the speed, but I'm trying not to get in trouble. We started looking at the actual distensibility of the pylorus to see really, was there a relationship? If you have a tight pylorus based upon its cross-sectional area and its pressure, well, if you relax it, do we see improvement? And one of the things I just wanted to bring up with this particular study is these weren't patients that just had gastroparesis and nothing else. There were so many other, again, anxiety, depression, Ehlers-Danlos, and hypermobility issues. So again, a complex patient that we're trying to target one particular hypothesis with this testing. And the thing that really has caught our attention is throughout the past 2 years, we started defining two patient populations. We said one patient population who, as we increased the balloon, the pressure would increase, so size, diameter and pressure, and then a group where there was this distensibility plateau. And we actually found they responded differently. And interestingly, the patients with the plateau responded better to Botox. The other patient population responded better to controlled dilatation of the pylorus. And some of these patients went on later on to robotic-assisted pyloromyotomy, a topic for another time. But we started to see, mechanistically, this is making sense. Again, sorry that I'm in 90 miles an hour, but I just wanted to make sure I touch on a couple more things. One, I just wanted to, when we talk biopsychosocial, when we talk autonomic, GI, and the mental health component, we did a study. It's actually, we started this about 10 years ago, where we started looking at functional brain imaging to get a sense of what was going on in these patients. And we were fortunate to have a control population that was healthy, no symptoms. And one of the things we found that patients who had particularly autonomic and nausea symptoms for prolonged periods of time had increased connectivity in certain parts of the brain, default mode network, saliency, and it was actually associated with overmonitoring, interoceptive hyperawareness. So again, chicken and the egg, is this the consequence of longstanding symptoms, or are there particular issues in the brain that actually correspond to the motility issues we see downstream? I'm just gonna, so I don't know if I have 60 seconds. My other area of interest is, how do you get all this data? It was brought up from our first talk. Parents with an overwhelming amount of data, you feel like you have a 30-minute a window to talk to the doctor, and it's almost like you're pressured, kind of like I am to do my last 30 seconds. So this is again taking David Sella's work with patient-reported outcomes and trying to take all that data and putting it into a manageable size or basically data board like I'm presenting here, is what our project is right now. But one of the things we found was that in order to optimize digital technology for symptom and history data collection, number one, it has to be bilateral engagement. If you make a device that the patients love and the doctors hate, it's not going to be used. If you make one that the doctors love and the patients hate, it's not going to be used. And so that has been the basis of our grant studies, actually doing focus groups to look at that interoperability with systems, number one, and with the stakeholders, number two. And I would be lying to you if I told you we've started to incorporate AI technology in our intake measures. Again, not to replace the clinician, but to actually organize and assimilate the data. Again, this is our goal, breaking down the silos to an integrated care model. And I think really we talked about the key things here, but hypothesizing and synthesizing information with both using data tools and actually having an eye-to-eye conversation with patients is essential. And it's a very humbling sport. So, I think the notion of having humility, empathy, respect, and the active listening and transparency, that's what we're trying to focus on. And if the technology can help us have the data so we can have more meaningful interactions, that to me would be a goal. This is my son's interpretation to COVID about many years ago when he was a kid. It just always resonates. And to his credit, at the age of 8, he's actually now a published author. They actually published this in a book in Illinois about kids' reactions to COVID. My point, there's always be optimistic, even when you're being, I guess, gnawed by a shark. Sorry for going over a little bit.
Thank you. Great talk. We have time for question. So I have one. You have, okay, go ahead.
Thank you. I'm wondering if your next career move is psychiatry.
Yeah, I'm trying to think of that. The truth is, we actually, part of my negotiating with where I work is to have a full-time psychologist embedded within our motility program, as not just as a psychologist to deal with mental health issues, but as a kind of a partner and in our clinical approach. She's also my research director for our program. So I think the thing about basic science, clinical science, and medical and mental health is you got to have a team, right? And so the master of all is the master of none. And so that to me is sort of that approach. And I think I'm getting too old to do any more careers at this stage. So, but I appreciate the.
And my question is from the perspective of multiple data sets and very complex one. You showed at the end effort to integrate it into something kind of like digestible for the patient and for the physician.
Mhm.
I'm wondering if you're thinking one step further about how to analyze this data that is so kind of like rich, but not, it's not hypothesis driven most of the time.
Agreed. So a few ways to answer that. Number one, we've maintained a clinical registry of all of our motility patients since the onset. So we have somewhere around 600 patients in that day, and it's painfully robust in the sense that all the data is there. So one, having the denominators is key. Number two, we're collaborating with the Department of Social Sciences and, again, computer engineering towards actually being able to cherry pick some of the data. And number three, to that point, we do have an analytics group that actually can search. So one of the things that comes up is putting this in an Excel spreadsheet is not going to quite cut it, and so we are trying to work on that now so we can actually pick that data. But are we completely there yet? Absolutely not. And have we had to go through iterations after 250 patients? Yes. Was it extraordinarily painful? Absolutely. But no, I agree. I think if the data is there, using the right, and even using AI, we've actually developed an algorithm through, ironically, ChatGPT, not to, again, answer questions, but to say, okay, here is the data that we scanned in. We're trying to pick these things out of it. So we're trying to leverage the AI part of things, but we're not quite there yet.
Thank you. Thank you.